So the B scan, and so I'll be doing a little bit of A scan as well, just to understand the concept. How do you? Yeah. So what happens here is that you generate ultrasound or sounds that have frequency more than 20,000 hertz, and there are piezoelectric crystals just like in a phaco probe which vibrate, and the sound waves that travel will go and come back, and the pattern that comes back, the reflectance, the amplitude, the amount of sound that comes back are analyzed by a system, receiver system, and then we can reproduce a image or a spike system. And usually the hertz level is around 8 to 10 megahertz. So higher the frequency, just as in light, there will be lower penetration. It will be scattered and you get a better resolution. But if you want to see the deeper tissues, like in the orbit, you might have to reduce the frequency, and you can see better the orbital tissues. And of course, we know the sound is high, the speed is higher in solids than in liquids, and the amount of the interfaces, they'll scatter, reflect, and refract as in light, and then you can count all that. And those that are the echoes will be classified as hypoechoic, or anechoic, just like when you have calcium. And there are two systems, the A scan and the B scan. A scan is time amplitude. There are single shots that go, and usually it's 8 megahertz. Then B scan is brightness amplitude. The earlier ones had about 10 megahertz. The modern ones will have about 35 to 50 megahertz, which can vary also. So A scan, just a short note, because we need this for our biometry. It's a single sound beam sent by the transducer, and the spike height will tell you the echo strength, and the strength will change according to the tissue interfaces, and dense areas will absorb more energy, and it will cause the reduction of the spike height. So if we know the normal heights, normal spikes, then we can keep that in mind and compare the spike height, regularity, the reflectivity, and the sound attenuation. So this is important to keep. Now we will look at the heights and look at the perpendicularity, whether they are perpendicular or not. If they are not perpendicular, we have not properly aligned the probe. So normally scan, that's a picture, then we can compare that, as I said, which I'll show some pictures later on in the various pathologies. And when we do A scans, we have to first get the gain high, and then you'll get the spikes, but you'll also get some noise also because of the function of the receiver and the transducer. So you'll have to then reduce the spike, reduce the noise, the gain, and see whether the spikes disappear, the behavior of the spikes. Then we can correlate with that, the findings. Sorry. So if you can see this one classic thing, melanoma and hemangioma usually is very much helped by the A scan. There was one case when I was the registrar, a hemangioma was removed because it was so typical of just like a melanoma, and we counseled the patient and we removed the eye enucleation, the proper procedure, and then we did the biopsy and it came as a hemangioma. And then the patient went to courts, high courts. That court case, my boss, still she is going to courts after 20 years. So it's not. We are very careful. So when you have done the tests, it's okay, but still you may end up with a court case. So it's always good to know what you might find. So the sound attenuation that you see the melanoma side, after the first spike, there's loss of amplitude. So that's characteristic in melanoma, which doesn't usually happen in hemangioma. So B scan is a brightness scan where it's a two-dimensional and directly over the eye with a coupling jelly over the lid. I prefer to do it on the open lids, not the closed lids, and then we can it will reconstruct a lesion and it will tell you the anatomical location and the shape, border size, all that can be calculated with the proper B scan. And if you can see here, there's A scan as well. It's always good to do A scan and B scan together. So it's usual detection where there are anatomical changes, topographic changes like coral detachment, foreign bodies, calcium, and tumors. And so there are hypoechoic, like white hyperechoic and anechoic are black. So that's important, optical empty spaces and all that. So we can go into the details of these, and they are available in the academy also, but the important thing would be to know how to do a B-scan. Now, registrars, how many of you do B-scans? Yeah, you have to do your own B-scans. Don't give it to someone else. In our days, you had to do a B-scan and you had to reconstruct the whole image by diagram. We were prohibited from taking printouts. I think Dr. Dias will know, Dr. Martin will know. With Dr. Makuladu, if you do a printout, there will be a funeral. You can't. You just have to prepare the whole thing. And you put some drops, put gel for conductance, and then put the probe. And the probe, there's a marking either on the wire end or on the top end, which can become erased after some time, so be careful. Sometimes you can't see the probe direction. Then you, on the open globe, you keep the probe in a specific manner. So you can keep it like this. So when you do that, you really see the other opposite side periphery and the posterior pole, rather the posterior side, and then keep on going. So the transverse, and you go around 8 times, you go around, and then you can see what you want to see. So as I said, combine A scans and B scan would help a lot in diagnosing lesions. Now, so this is a RD. So usually the reflectance is very high. So you can increase the gain to around 80 or 100, and you will see the lesion, the funnel shaped lesion. Sorry about the quality of the image. Then you reduce the gain. In the gain, you can reduce around 60, 30, 40. So usually, now you can see the RD, usually is attached at the optic disc. So you know there could be RD. But sometimes you might miss it with the PVD. So if you do it carefully, you can see there's a free end, not attached to the optic nerve. And in PVD, what happens? When you keep reducing the gain, at one point, the shape is lost. You don't see the shape. Then you know it's a PVD. That's how you differentiate between RD and a PVD. Anyway, even at 40% of gain, you can still see the line. So this is giant retinal tear. Again, might be visible, necessary in a patient with hyphema, orbital trauma, blunt trauma, where you don't see the inside, hyphema and all that. So what you can do B scan, the way I showed you, and then, sorry, you can see the tear end, usually rolled inside when we do go around the limbus in the way I showed, and then you can alert the retinal surgeon. So if you see abnormal shape, so think of staphyloma in pathological myopia, or it could be an excavation that you see in funnel collobomas. So then say if you get abnormal results when you do the biometry, then you think of, and with low results also, myopia, you have to think staphyloma with tessellation. So you go in and do and see whether there is a excavation like this, and then you can map it. Now this is subhyaloid hemorrhage, and is located preretinally. So here what happens again, you see the lesion in the B scan. Now A scan also shows some moderate amount of amplitude and with low attenuation, not high attenuation. Then you think of blood, like in hemangioma, and then you reduce the gain, and you can see that the anterior, the area where it's limitation, might gradually loses its reflectance when you reduce the gain. Then you know it's sort of hemorrhage, and it's not retina. It's not a subretinal thing. If it's retina, the gain will not. When you reduce the gain, is still the reflective will be high at the anterior end. So this is what the choroidal detachment. In the lower diagram shows the typical kissing choroidal, the kissing choroidal, where they are attached. Especially after trabeculectomy, if the pressure is very low, you have to rule this out. The typical shape is obvious, and here the reflectors will be 100%. Usually, reflectivity will be equal to the sclera, the choroid. Usually they are equal, so then you know, even you reduce the gain, still it doesn't go down. The choroidal detachment. So what is this? So this is a mass. So vitreous cavity is filled with the lesion in the B scan, and with the A scan down, you can see it as high amplitude, moderate to high amplitude. Again, attenuation is variable, and it's a patient from a patient with retinoblastoma. This fills the vitreous cavity, very, very late stage. So this is from patient after cataract surgery, about 10 days after, severe pain, redness, and when we do this endophthalmitis, again extensive vitreous echoes, and there are membranes also which do not reduce their gain, reduce their reflectivity when we reduce the gain. So endophthalmitis and panophthalmitis will show like this. So this is from a posterior scleritis, the typical T shape that we go for in the diagram below. So there's the thickness, increased thickness in the sclera. And the top is from optic nerve head drusen. We know optic nerve head drusen can create havoc. It looks like papilledema sometimes. Vision is also lost, and you do all the investigation, you can't find out the reason. And usually, I think the best test in our setup would be a B scan, where you see that hyperechoic area showing these. So this is the posterior scleritis T sign, and so drop IOL will show reverberations. You can see that multiple sharp hyperechoic lesion, the area in the posterior part, that usually denotes dropped IOL. So that will help you to see after blunt trauma, again hyphema, patient loss of vision and hyphema, if you suspect a drop IOL, or even in a patient, when we see drop IOL after surgery or whatever, it's always good to see and see the pattern that what you see. So these good to know the differences between choroidal nevi and melanoma, how they show in A scan and B scan, and these will be asked in the exams also. But more than that, as I told you earlier, it's good to know how they present to avoid wrong management. These all available in academy books. So that's about B scan. Now we'll turn to biometry. So biometry is the measurement of anatomical dimension of the eye, simply that. And so we will be measuring corneal curvature, axial length, and anterior chamber depth. So why? Because corneal curvature will tell you and give you an idea about the corneal power, which can be around 45 diopters. So the curvature is related to the power of the cornea. So in the measurement of the total refractive power of the eye, we have to know that. Then axial length. So axial length will tell you whether it's very myopic or hypermetropic, and then we can have an idea to have what the power that we have to have to when we replace the eye for the lens to have a emmetropic or whatever the target emmetropy that we want to have. Anterior chamber depth will ultimately help, along with corneal curvature, to give ELP, the effective lens position, ELP. They are dependent on those, so that also is very helpful. So that's biometry tells you all this data, gives you all this data. So before we venture into whether we are going to do optical or non-optical, so measurement of our cornea is based on, as I said, on corneal curvature. So we make two assumptions. The first assumption is that cornea is a spherocylinder with a fixed ratio between anterior and posterior curvatures. This is usually correct, but it may not be correct at times, especially after trauma or after refractive surgery on the cornea. So anterior corneal surface is a convex mirror. So the images, Purkinje images, will help you to come into the power of the anterior cornea. Then you can, from that, because the first assumption, you can calculate the posterior corneal power. So if we are in doubt, we can resort to topography. And with Scheme-Flood principle, we can measure anterior and posterior separately and calculate the true corneal powers. So entrance pupil is like an image of the pupil that is sent back on the cornea, which tells you the effective area of the cornea that takes part in refraction. So it's the central 4 mm area It's manually is greater 3.2, but automated is about 2.6. And of course, we know 41 to 45 tells you it's a normal range, is a normal thing. Less than 41 flat and 45 deep, where you think of keratoconus and other corneal ectasias. And of course, it's always good to do topography if possible, if there's an astigmatism in the corneal powers more than one diopter. So topography, these values may be normal. There's an old slide. I think now it's not 5,000 points, must be 10,000 points, where you measure the corneal power in each point, important points, and then you derive at the. Now this is the assumption radius is the posterior corneal surface radius is 1.2 mm less than the anterior, which is usually 7.8. Yeah. So one diopter error will cause a one diopter error in the IOL power also, and also in theoretical formulae like SRKT, this will predict the ELP also. So if you make a mistake here, you will make mistakes in the error and also in the ELP also. So in my our practice, I'm very concerned how they do measure corneal power, because here if you do it in a rush, you can make great mistakes. And the axial length. So axial length is the anterior surface of the cornea to the RPE. So, and it is usually measured in millimeters. Yeah. So you can measure by ultrasound via immersion technique. You put an immersion fluid on into the eye, and then without direct contact you can do, or you can contact and do, but then you can cause indentation and can cause errors. It's always good to have immersion nowadays. And the other way is of course optical, which we'll come to later, like using system like IOL Master or LensStar. Usually it's very accurate, especially if there's a change in the retinal or the eye globe surface, like staphyloma and silicon oil. And of course, these may not work when there are media opacities like corneal scarring or mature cataracts. Or for any that matter, for any media opacity will compound the findings of optical methods in measuring axial length. The thing is here, the errors in axial length can have a devastating effect on the final outcome. The shorter the eye, greater the damage. So it's a shorter, like 20 millimeters, you can have almost 4 diopter error in the axial length when you have error. If it's a myopic eye, it's less, but still there will be an error, 1 millimeter difference. But most of us have ultrasound, not the optical methods, and you have to master. It's a technician dependent thing, and you should know these speeds, what will happen inside the eye. So speeds will have greater impact. So again, now we are going along A scan. So A scan now. A scan is important, as I said. When the spikes are perpendicular, then you know you are doing it properly. You have to focus directly to the fovea. So after some time, you gain confidence that you are aiming the scan probe at the proper place, that you get all the axes correct. Now, if we do the other way around, optical biometry, what happens is light. Now we know in ultrasound, we use sound which goes and come back, reflectance. Now light is very fast. The speed of light is very fast, around 300,000 kilometers per second. So we can't do a reflectance. What you can do a sort of trick in the eye, trick in the system, where you have a beam splitter. You split the beam, make 2 rays from out of one laser, and then you send one through the tissue, other to a reference place, and then compare. And then you can reconstruct again in a different format. So that's the difference between sound, ultrasound, and lens splitting, the beam splitting in laser, light optics. And there are 2 systems: partial coherence interferometry or PCI and optical low coherence reflectometry, OLCR. The partial coherence, they use lasers, so it's almost infrared. The resolution could be around 12 micrometers. So it can measure the axial length and the AC depth, and and I think newer IOL 700 can also measure many more than this. So our typical example would be IOL master. Then for optical low coherence reflectometry, it's a reflectometry. It can measure axial length, corneal curvatures, corneal thickness, lens thickness, retinal thickness. So it can measure so many other variables. And the typical example would be lens star. I don't know whether we have it in Sri Lanka. The lens star uses something called thick lens formula. I hope those who did optics must know that thin lens formula and thick lens formula. So thin lens formula is an assumption that we make to calculate, but it can usually, usual settings it will be okay. But when we take other scenarios where extreme hypermetropia, extreme myopia, they will not be accurate. So then it's better to have exact ray tracings. You trace the rays, how they behave inside the eye, the lens, and then so the theory wise, lens star is much more accurate, right? And it uses a factor called C factor in Olsen formula. IOL master also nowadays the 700 has measured so many variables like axial length, K readings, and of course the number 4 is you feed into the system pre op refraction and AC depth and lens thickness and other factors you feed and you can get. Now these 7 parameters come from Higgs formula. So if we compare the two systems, the optical biometry where I use lens star or IOL master, feed everything and then wait, or the ultrasound scan. Optical is of course far superior, is non-contact, so patient hassle is much less, and it performs everything, almost everything. It performs keratometry as well, is far more accurate and repeatable therefore. And of course it has built-in IOL formulae, so you can just select your formula that you want and then you can get the result. The downside or the disadvantage would be it needs focusing. So if the patient can't focus, for that matter, if there's a media opacity like corneal scarring, thick cataract, thick PSC, vitreous hemorrhage, of course, then it may not be accurate or sometimes it may not be usable even. That's the optical biometry part. Ultrasound biometry, yeah, it's in those situations is much better, like when the vision is very low, where the patient can't focus. There's corneal scarring, eccentric fixation because of retinal dragging and other retinal diseases, macular degeneration, where you can't find a proper place. This comes in handy. Only thing is that the operator should be able to do it properly. It's operator dependent, and I would like to thank all the operators in our peripheral hospitals where they do a good job with very limited facilities and broken scanners. They do a wonderful job. Now, when possible, what I do in my practice would be, first I would ask the operator to do a ultrasound scan biometry and get the results. So I would tell him to see that the spikes are correct, perpendicular, and he would do several and see whether they are all repeatable, and then get the powers. Then I would ask him to go back and do IOL master. So IOL master will tell you it's all IOL 500. It will tell you the details. Now what I would look at would be first the axial length, the two sides. If there is more than 0.3 millimeter difference between two eyes, I would want him to repeat it. Right? That's the first thing. So you get the axial length first. Are they equal? Almost. If they are not almost equal, if there's a difference more than 0.3 millimeter, you have to be alert. Then, when they are equal, if the lens powers are different, then again I will ask you to go back and check. That's number 2. So then these things are okay. If you double check and you get the same result, then you will go back and see what the powers are, and you will see the lenses of your choice and see how they are comparing. So that's what I usually do. So which is better? Optical or ultrasound is not the proper question. It depends on the context, whether the patient can see or not, or whether the media are clear or not. And depending on that, we will choose whatever is available. And whenever if you can use optical biometry, of course, it's far, far superior and more accurate, and things are much easier because it has built-in formulae. But if the system demands that you use ultrasound scan, then you must be ready for that also. So we did 2 lectures, I think 5 minutes left. And thank you for listening. I can answer questions after the sessions. Thank you.